Well, welcome to this pharmacology drug class review in the large category of anti-diabetic drugs with a very specific focus on insulin and all of the various formulations. There is no doubt that insulin works to gain acute and chronic control of both type 1 and type 2 diabetes, but it clearly has its own issues, and that must be factored in a patient-specific way. Hey guys, I'm Dr. Busti. Thank you so much for joining me on This Is Why, a show dedicated to helping healthcare professionals understand the why behind the pharmacology and drugs that we use, because that makes the why, when we understand the why, it makes the how much easier, doesn't it? That mechanism starts to make sense, side effects start to make sense, monitoring parameters, and eventually our counseling points. Now, with all the drug class reviews that I do and cover, we hit the core content first, and that includes what drugs make up that drug class, what's the indications and common uses in clinical practice, not all of them necessarily FDA approved. What is the net benefit? Okay, why do we preferentially pick it when we need to pick it compared to other options? So we learn things in the context of other drug therapy as well, and then we dive into pharmacology, and then more importantly with this one, which has a little bit more than other drug classes, is how do we use some of these drugs and apply them differently. There's more than one way to manage diabetes, and it needs to be considered in a patient-specific manner, which is why I said that at the beginning. Okay, so with that, let's jump into now our agents. Now we have a number of options, okay, and we'll continue to have more formulations and options and brand names and biosimilars and all these things, so don't get hung up on that part of it. But from all 30 years of my training and career in pharmacy and nursing and medicine, these drugs have been around. Obviously, the longer basal-acting agents have evolved. The ultra-rapid introduction has evolved. Really, that's just tweaking some of these things to achieve certain types of pharmacokinetic dynamic effects that we need for that particular situation. So we have short-acting agents, most commonly regular insulin, and we have the rapid-acting agents like insulin, aspart, glulisine, lispro, those agents. We have intermediate-acting, historically being our NPH insulin, okay? And then we have our long-acting, or what is really trying to mimic that basal insulin, because that's what our bodies do. We'll see that here in a minute. The reason we have so many choices is to try to replicate and mimic the normal physiology in that patient care scenario. We even have formulations that come in more concentrated amounts, like so patients on high dose, they have a high degree of insulin resistance. That is what it is. But you don't want to be injecting large volumes of things into your tissue if you can. So that's where concentrated formulations, or now even continuous pumps, can be very, very helpful at managing some of the overall disease. Okay, now we're going to shift over into our common indications and uses in clinical practice. Now, not to insult anybody's intelligence, we're treating diabetes, right? But this one is important that it's not just obviously type 1, it is also type 2. We'll see it when we get into one of the tables that I have for you. The impact of insulin is sometimes needed when the other drugs don't work, and that happens. When you look at the totality of the evidence, right, when you need to get glucose under control, especially when it's really high, when those A1Cs are over 10, insulin is going to be the only thing that's going to get these patients under control. And then you can consider other treatments, but then you still may have to migrate back depending on the degree of compliance. But we use it also in gestational diabetes, and we for sure use it in diabetic ketoacidosis, or DKA, or HHS, hyperosmolar hyperglycemia state or syndrome, right? Those conditions more acute, we need parenterally administered options, and we need to control the drug very specifically in that acute situation, okay? And we also have, obviously, hyperkalemia. So one of the treatments of driving the potassium back into the cell is the use of insulin. Now, it doesn't solve the underlying problem of hyperkalemia, of course, but until patients get to dialysis, we may have to do that to try to achieve some stability so that the patient doesn't go into basically a life-threatening cardiac dysrhythmia. right? Basically pulseless electrical activity. Happens all the time, okay? And I see it on the side of the emergency department because patients miss their dialysis, for example, and they develop severe hyperkalemia. So we need to recognize when we use these drugs and how we use them differently in different situations and based on certain diagnoses. Now, what is the net benefit? Obviously, for type 1 patients with type 1 diabetes, they lack insulin. So we have to replace and give them back the thing that they don't have. We'll see that here in a minute. I'm going to walk you through that because it's important, and that's what goes back to all these formulations. But without it, we can't drive that glucose into the cell so that the metabolic demands of those cells can get the energy substrates they need, right? Now, insulin also not only does that, but it helps to regulate also even postprandial glucose. And so we have formulations that help guide us, and that's why you'll see combination insulin therapies. That's appropriate, and there's, again, many ways to do it. So the net benefit is it gets the glucose down and under control, period, no matter what. You can give enough, a certain amount, it will get it down. Okay, if I have to put you on an insulin drip to do it, so be it, right? But it works. Now, it comes with side effects in doing that, but that's the main effect that's so important for us to recognize. Okay, now we're going to kind of migrate over into pharmacology, and when we do that, we're talking about, again, mechanisms, some kinetics. We're going to start diving into more of these details that I kind of been talking about, all right? So obviously, with the pharmacology, we're replacing endogenous insulin, especially if the pancreas and the beta islet cells don't make it, or it's insufficient. So some patients go through phases. I'll never forget one of the first patients I ever saw in my own training. We weren't sure. I mean, even the endocrinologist wasn't sure if the patient had new onset type 1 or they were developing type 2, or the patient ended up progressing on to type 1. So they had some functioning pancreas still there, but as the autoimmune attack occurred, he lost more and more and more of his function, and it became very obvious he was not making insulin anymore. So, you can see people depending on where they present in the timeline of their disease, okay? But what is insulin doing? It's not just driving in glucose into the cells just to change the blood glucose level. It's to facilitate that metabolic need of the body and the cells and that organ. And there's a lot of organs that use it, okay? So it impacts carbohydrate and fat and protein metabolism. It helps to regulate that. It also can control the production of glycogen in storage forms, right? So when we have extra glucose, our body's going to retain that in the storage form, which is the glycogen, right? It decreases lipolysis, abnormal fat breakdown. Well, you might need some of that fat breakdown, but in an abnormal way, we don't want that, right? And it also increases the uptake of and utilization of triglycerides. So what are we trying to mimic? Well, let's just step back for a second and think about the normal physiology. Patients without diabetes. No type 1, no type 2 here, okay? This is the example of what we're trying to mimic. Most people, and culturally, traditionally, eat 3 meals a day. Maybe they intermittently snack, okay? And so you see that the blue line represents the plasma insulin levels. They're very sharp, rise, and quick, and go away. The little bump here, in part, has to do with the post kind of meal, depending on what you've eaten, right? There's sometimes a second little peak there. And then the red line represents that basal insulin. So you will always make some or release some in a small amount, and that becomes relevant when you think about insulin pumps. Patients, type 1s specifically, some type 2s that are difficult to control, they'll have intermittent boluses, and then they'll have basal amounts that they can receive. Why? Again, we're trying to mimic this. And so you want to create those response curves to create the expected and desired physiologic effect, okay? That's fundamentally what it's about. Okay, so I put together this table for you, and I recognize that it's pretty busy, and I can also respect that maybe those of you watching the video can't see every word or read the font. I get it. It's okay. I put the link to the page that has this table for you. Okay, thisiswhy.health, it's for free. Okay, so whether you're on our podcast channels, Spotify, Amazon, or Apple, those kind of things, you can go to the description, YouTube, go to the description, and the link is there for you to be able to get these for studying, for reference, for sharing with others, for teaching if you're a preceptor or faculty. Use it if you feel like it's helpful to you. But what it does, I'll kind of walk you through it, is that each row represents sort of the type of insulin and its kind of onset and duration. So we have rapid acting inhaled, we have rapid acting injectable options, short acting, intermediate, and then we get down to that long acting basal insulins, right? And then there are some rows in between, sort of in that section, that represent the different formulations. Like, so for example, in the rapid acting injectables that you see right here, we have insulin aspart, insulin lispro, insulin glulisine. All of those are known to be rapid acting insulins, and you have to memorize that. There's no intuitive way. Unfortunately, there's no why. It just is what it is, right? That's the name. And then, of course, the brand name is in the third column. And this will continue to grow, especially as the biosimilars grow. I've tried to put in a couple of them in here, but listen, guys, this is not an exhaustive list of every option that exists. I'm trying to give you the big picture here. Now, you will see some, for those of you that do see it or download it, you'll see some letters and abbreviations there in parentheses, and you'll see those letters carry over into the pharmacokinetic dynamic effects, so the onset, the peak glycemic effect, and the duration, so that each agent has its own unique, specific kind of profile. But relatively, you see similarities. We're within a range, because it's never going to be exactly these numbers anyway. So, memorizing this kind of stuff is, in my personal opinion and clinical experience, is not the point that's relevant. It's understanding the generality and the interval or the range that you're dealing with, right? So that if I want to mimic kind of that physiologic onset of a rapid acting effect, then I'm looking at an inhaled rapid acting or a rapid acting injectable. My short acting regular, which is historically the drug that most people know about, have experienced, depending on if you're a healthcare professional, you've seen, used, administered thousands of times. The problem with it is it has a much longer duration of action compared to the rapid acting. It also has a slightly delayed onset. So it doesn't really mimic that desired physiologic effect. And so the risk of hypoglycemia is there. It's legit. You have to time your meals, and you have to time it with a shot. And that's inconvenient for many patients. It's, depending on what they do for work or activities, that may not be feasible. I have a colleague who has type 1 diabetes in the emergency department, and that he has to carry granola bars and things, and he has to very specifically try to target when he's going to eat and use his insulin. So that's okay. Recognize and make sure you ask about your patient's lifestyle. Understand it so that you can take these kinetics and these things and apply them to that patient scenario. When you look at the long-acting basal options like insulin, Glargine, Detemir, you're getting into that 24-hour bubble, which is why they can be administered once a day. Now, I will say that Detemir has a dose-dependent effect, which is why you see 6 to 23. Sometimes those patients have to be on twice a day injectable to get a more flat basal look. And so I put together this graph. I've seen it and used this for years in many of my lectures because it represents that visual, the thing that helps you to wrap your mind around the numbers on that previous table. Okay. And so if you can kind of think about that and mirror that on top of that physiology that I was showing you earlier, then it starts to make sense in the hours. So if I administer a drug like aspart or glulisine, then where is the peak insulin effect in that time frame after the injection? Because that's when my peak glucose should be there as well, as much as possible. Okay? And you can see that regular insulin has a wider curve. So it's going out in that 6 and 8 hour bubble where, like, wait, we don't need it hanging around like that. Okay? Now, cheap, available, effective, historically known, blah, blah, blah. Nothing wrong with it. You just have to factor that into the patient management scenarios. Now, when you get into the Degludec and Glargine, these are more commonly your basal insulins. Like I said, the Detemir formulation does have a little bit more of a peak, and that's where patients sometimes have to be divided out, especially when they get to those high doses. So anyway, I hope that brought some degree of clarity for you as we start to now dive into this, is because it's so important to understanding the next steps of things that I'm going to cover, which is how to apply them to patients. What's the dose? When do I administer it? When do I check my glucose level? How do you counsel them to monitor that if they're not on a continuous glucose monitor or on a infusion pump or something? I mean, that's the strategy. You have to. Not everybody's going to be able to get on those treatments the way you might want that gives the best overall control. There's a lot of things in clinical practice that I would like to do for patients that I can't do, right, for one reason or another. So you have to know the bigger picture. Okay, so now let's start to think at a high level. So, I said insulin is used for type 1, type 2. So in this table, this just represents the general treatment strategies. You have medical nutrition therapy, exercise that must be the baseline. It's the core, it's the foundation. And then obviously with type 1s that lack insulin, they need that replacement. And we're going to talk about some of the strategies on how you dose it and use it and the different number of shots and blah, blah, blah. Then there's also the pramlintide can be added. That's why it says plus or minus. That's for a very specific patient population who desires very tight control and may need to lose maybe 1 or 2 kilograms, right? Not much weight. But that's tailored tight control for someone who's educated and wants to be very well, minimize their long-term complications. Whereas type 2 diabetes, yes, you have the medical nutrition therapy exercise, but you see that the first things that they're trying to advocate and that we do is to try to avoid insulin and drugs that would increase the release of insulin, the secretagogues essentially. Why? Well, because while insulin works, it causes weight gain. It increases the risk of hypoglycemia. Those can create problems. And so if we can avoid that by using a non-secretagogue, a non-insulin-based treatment, especially for type 2, obviously, then we should try to do that, okay? Now, obviously, then you see very quickly there's the addition of an insulin, and it's usually a long-acting basal insulin, added to it because it's not going to cause extreme drops, and it's lower risk of hypoglycemia. But sometimes that gets there, but then you have to progress on that when these agents, sometimes people on 2 or 3 of those non-insulin drugs and they just are not getting to goal. Again, you can get anybody to goal on insulin, just that takes a larger amount, and you're going to see unfortunate weight gain. So as we think about our treatment options, we have insulin, which we're talking about, but in the big picture, there's the secretagogues, the meglitinides, sulfonylureas that increase the release of insulin. So they have the same side effect problems, weight gain, hypoglycemia risk. And then there's the evolution of all the non-secretagogue, non-insulin-based treatments like alpha-glucosidase inhibitors, the biguanide metformin, DPP-4 inhibitors, GLP-1s, GIP-GLP-1s, SGLT2 inhibitors. All of those in this table that are summarized give you the different mechanisms and some of the classic agents in there. So again, when you're thinking about type 1 versus type 2, and you think about the general approach, again, general approach, where does insulin fit Well, it fits very early in type 1. It starts to get introduced and added on differently in patients with type 2. You start out with the basal, then you add on other insulin therapies if the other non-insulin, non-secretagogue options are not working, right? Because again, we're trying to preserve in type 2 and prevent the progression of that beta cell burnout into disease. We're also trying to prevent them from gaining more weight, which is part of the problem, okay? So again, I'm just trying to make sure you have your mind wrapped around the big picture, the general approach, because the guidelines are going to pivot around this, that, and the other, and the new formulations are going to sometimes show up and come and go, but the strategy and the intent and the goal in a patient-specific manner has largely remained the same for my entire 30 years. Now, I didn't have, early on in my training, didn't have GLP-1s, DPP-4s. So today, we can manage, and I see the management of patients with diabetes and much better. So yeah, we're improving it. But the strategy has always been evolving into trying to maintain glucose homeostasis, prevent weight gain, and create sustained A1C reductions. That is the net effect. Now, when you look at drug tables like this one, where we have what comorbidities or factors do we have to be careful, avoid, use? Now, this is mostly in the context of the non-insulin, non-secretagogue options. But over here is you want to be careful with insulin, obviously, if someone's already overweight. So that's that type 2 patient. That's where you would be most concerned. There's nothing wrong with using it in any of these comorbidities. It just can gain more weight, okay? Now, moving on, we're going to start diving into some of these dosing considerations, and I'm going to try my best to not overwhelm you with every little detail and nuance, because again, those of you that may be earlier in your training, I'm trying to just give you the general approach, but it is, there are clinicians who are very specifically trained to manage these because it requires that at times. I've got clinical pharmacist colleagues who are absolutely amazing, do a great job of managing these patients and manipulating all of their medications to achieve that effect. Endocrinologist colleagues treat the very extremes and difficult scenarios, and they use and manipulate these drugs. And so I don't want to minimize when I go through some of these a little bit and generically, that I don't want any of you to perceive, well, it's just that easy or whatever, anybody can do it. No, we need to be very careful because a bad experience in a patient experiencing hypoglycemia or developing weight gain that causes them more problems and that causes them leads to depression, and I mean, that's not helping the patient. So we have to understand the pharmacotherapy to achieve the best result for our patient. And so there are no perfect one-size-fits-all treatment for every single patient. And the strategies that we use for type 1 versus type 2 are different. The doses, why? Well, because patients with type 2 diabetes have traditionally more insulin resistance. So their metabolic needs and the requirements for insulin is different. And we have to be very careful with that. You need to respect that pathophysiology perspective. Because if you throw on insulin to a type 1 patient, you could cause significant acute shifts in their glucose because they lack the insulin sensitivity. Whereas I can give a much larger dose. I've got a lot of forgiveness clinically for a unit or 2 units here or there of insulin because they already have resistance. They don't get significant fluctuations when I give patients insulin with type 2 diabetes. I get subtle changes and sometimes not what I wanted, okay? All right, so now we need to think about how do we know the effect? Well, it's in relation to the timing of what we administered. Again, most people typically having 3 meals a day. You can see those represented here. We have breakfast, lunch, supper or dinner, and then sometimes a bedtime snack depending on what's going on. in that patient and their need. And then what you see is, represents the morning, again, lunch, PM. These are the doses of the insulin that we would typically administer, rapid acting usually, or short acting. We eat, and then we need to check the sugar, right, or the glucose. And so this is our self-monitoring blood glucose recommendations, especially early on when you're trying to figure out, well, what insulin dose is going to work for you? I don't know. I don't know your lifestyle, your dietary habits. I need to see the trends. So I need you to journal for me some of the ways that you eat and what you eat and how much I'm going to need to tweak these doses. I can't tweak them unless I have data. And that's what this is trying to acquire. So when you see here it says a 2-hour post-meal check, I'm trying to figure out where you're at. How did that insulin cover your meal? Again, depends on the meal, but also it depends on the timing and the duration and extent of activity of that insulin. And so one of the things that I wanted to walk you through here is when you consider the initial dosing of a short-acting or rapid-acting compared to a intermediate or longer-acting like an NPH or basal insulin, when are we checking and when does that blood sugar kind of point to what you had done before throughout the day? So if you look at the x-axis on all 4 of these, that represents a 24-hour period of time, and the color of the line or graph is just mimicking the coverage of that insulin and that the way its kinetics, again, generically kind of look. And so when does the blood sugar reflect the insulin coverage? So for short-acting, rapid-acting, you can see that what you administered in the morning over here around 8 o'clock is really manifested more around that noon hour. So it's your breakfast and going into lunch. And then, of course, what you administered at dinner time is manifested in part, okay, right before bedtime, okay? So that's how you try to think of the rapid-acting, short-acting. When you have an intermediate, like NPH, you might administer the NPH here in the morning, but that's covering you through breakfast, into lunch, and towards dinner. And so your PM, or kind of nighttime, reading, is reflective of that NPH throughout the day, or that NPH dose where you would want to modify it. And then the same thing is also in the morning. Okay, so when I give an NPH in the morning before I eat, so up over here, before I eat and before I administer the next dose, what is that blood sugar doing? That is reflective and part of my basal insulin or long-acting. Again, the reason why this mindset or mentality of insulin and kinetics and its application matters is because you're trying to figure out how much of the drug and the insulin to tweak where. If they're on a two-shot regimen, if they have a combination of 70-30 insulin, or they have an insulin, where do you need to make the modification in the number of units? And how you do that is influenced by the kinetics, it's influenced by the formulation, and it's influenced by the patient's lifestyle and dietary habits. All of that matters. That's why you have to collect some information to guide you on that, okay? And so rapid or short-acting agents, which mimic that physiologic kind of effect, are thought to have maybe a little less risk of hypoglycemia than regular short-acting insulin. And the reason mainly for that is just due to their shorter half-lives and durations of actions. They're mimicking typically what would happen around a typical meal anyway. The ultra-rapid insulins have demonstrated to have some potential improvement on postprandial excursions, okay? Generics are available in a number of these formulations, and again, they come in combined with a intermediate and a rapid-acting or a short-acting component, like 70-30 insulin, 75-25, okay? All of these different formulations all need to be considered. We have insulin that's approved for pumps, where they're automatically being delivered in a basal and intermittent route. We have pens that are even designed at half a unit for pediatric patients. All of these formulations, being short-acting options, can show up in different places. And that's why it's important to recognize and read the product and understand the product formulation that you're dealing with. Now, patients with type 1 diabetes, the dosing considerations, initially it is weight-based. But we're going to very quickly, over the next week or two, as we implement these, adjust them in a patient-specific manner based off those self-monitoring blood glucose levels. Okay? So a common way, it's not the only way, but a common way of trying to wrap your mind around, well, if I have a type 1 patient, they need basal and they need a rapid-acting or short-acting option. So how do I do that? Right? If my total daily dose of insulin is somewhere between 0.4 and 1 units per kilogram, okay, then how do I divide it to the short-acting and the long-acting? I mean, some people get this really confused, right? It's not straightforward sometimes. So I want to be very clear that when we first start out, we have to start somewhere. Most people are going to start out and err on the side of a lower doses regimen, especially with type 1, with very little insulin resistance, and we do a 50-50 distribution of that total daily dose. So we figure out what's the total daily dose first, then we divide that total daily dose into a 50% of that dose is the long-acting basal component, and the other 50% is the bolus or short-acting component. Again, we're trying to mimic that chart that I showed you earlier of the normal physiology. So if you can keep that imagery in your head, then the 50% of the total daily dose of insulin that we would give, that is a rapid or short-acting that goes up around those meals, well, then you take that 50%. So let's just say the total daily dose is, I don't know, 100 units. I'm just making up. Then we divide it by 50, right? So then it's 50-50. This 50 then has to get divided into 3 doses to mimic those meals. So you take 50% or the 50 units and you divide that by 3, roughly, again, roughly, the beginning, and that's how you would distribute those around your meals. Now, you might find out that, okay, well, that's not going to be equal, taking 50 divided by 3 and just equally distributing. Maybe my main meal is in the morning, or maybe my main meal is at night. Well, that'll adjust of the 3 shots that you give. If you're doing a 4-shot regimen kind of scenario, right, where you have the rapid acting and the short act and the long acting, well, then you're going to tweak those. And that goes back to understanding when the timing of the insulin was administered in relation to the meal and what glucose you're reading. Okay? Patients with type 2 diabetes, again, the dosing is going to be patient specific, but there's a number of different ways to do it. Because remember, sometimes we're starting off with a basal only. Okay? And you can start off, for the most part, at 10 units of a basal insulin in those patients and probably be okay. Because remember, they have a larger amount of insulin resistance metabolic syndrome. But remember, if you go back to that general approach, we tried non-insulin, non-secretagogue options first, combination therapy, and then when that doesn't work, we add on insulin, usually a long-acting basal, and then we start adding on more insulin to create the titration effects that we need to get the control. Okay? So if you are converting between basal insulins, it's usually 1-to-1. So whatever, if you're given 10 milligrams of insulin or Lantus and you want to convert to another option in the long basal insulin, it's usually 1-to-1 in most cases. Okay? Now there are some rules that you can consider. That if you're on insulin Glargine conversions and you're trying to get to it, right? You might go to 80% of the total daily dose if you're on NPH on twice a day. So you want to convert them to Glargine. Error on the side of precaution. Again, you don't want patients developing hypoglycemia and having a bad experience, because they're not going to trust you, and then they may not even be compliant because they're going to be scared, or they're going to reduce the dose themselves without you knowing it. Okay? All of those scenarios happen. And so the 80% kind of consideration when you're transitioning from one option to another is safe, but you need to realize that it may not be sufficient to get them under adequate control. Nothing wrong with that. Okay? Nothing wrong with that. Now, basal insulins, especially if they're on monotherapy basal insulin with their other drugs and you're in a type 2 scenario, type 2 diabetes scenario, then every 3 to 4 days, making adjustments by 2 to 4 units appears to be an appropriate general way to do it. Okay? Now, if the patient develops hypoglycemia, then you should probably consider a 10 to 40% dose reduction, okay, in that patient based on the severity of their symptoms. So again, there's no perfect one way to do it for every patient. You can put 5 clinicians in a room and ask them, you're going to get different answers sometimes. But it should be within relatively these guidelines, if you will, general approaches that can guide you as you're starting to learn how to do these things, depending on what your level of training is. But we want to be careful, and we want to make sure that they understand how to treat the hypoglycemia. Now, if you are using insulin and you're doing other different formulations, so for example, NPH is obviously going to have to be divided in a twice-a-day regimen. Well, how do you do that? Well, NPH typically is, you can go 50-50. So if again, you have you first calculate the total daily dose of units. You divide that out to the long-acting and then the short-acting. And then if in the long-acting, if I'm going to divide it out, I can just divide it by 2 at 50-50. So going back to my example of 50 units, then I'd give 25 in the morning of NPH and 25 in the evening. That's one way. Most people tend to eat most of their calories and consume things throughout the day. So typically you'll see patients or clinicians do this. 2/3 of that 50 units is in the morning, and 1/3 of the 50 units is administered at night to cover them for dinner and through the evening. Okay? Because in the middle of the night, you don't want them plummeting their glucose and then having hypoglycemia. And so there's all these strategies that can help you manage that and deter the risk of hypoglycemia, okay? Some people have even advocated, this was more back in the day when we didn't have long-acting basal insulins, we would use NPH insulin in lower doses, but give it 3 to 4 times a day to create basically a smooth curve. Well, that's 3 to 4 shots, okay? Or you're having to mix it with the right type of insulin. So when we go back to, the whole point of these conversations is to go back to that mirrored image of the physiology. So when we look at our rapid-acting drug like lispro, and you overlay it on the normal physiology of the rapid-acting insulin that would normally happen in our bodies, that's in a glucose-dependent manner, you are trying to mirror that. Okay? The basal insulin down here is mimicked by our Lantus, for example. This is just an example here. I'm not saying that it's the only drugs you use. But these are common options. And so this one would require a 4-shot regimen. You got to give the basal insulin here in the morning. And then you have to administer 3 more shots around your meals to create that. And so that's a nuisance, isn't it? And that's why I developed pens and things like that so that make it convenient for patients. But that's where the evolution of infusion pumps also came in. So they could just do this by reading the numbers and just correcting it based on a range. Okay? So what the next couple images are trying to really just walk you through are the historical regimens where you're using like a regular insulin or a short-acting with a NPH scenario. So the green line here represents NPH. You have to do twice a day. You see the peaks that it can create. Anytime you see a peak with insulin, you have a risk of hypoglycemia if you don't have adequate glucose. So if you're not snacking and eating. So snacking and eating in a type 1 is very important. Very important, okay? So this is just showing you a 2-shot regimen. This is where if it's an NPH and regular insulin are combined, whether you mix them together or they come pre-formulated as 70-30, 75-25, right? Down here is a 3-shot regimen where you separate out the regular insulin. So maybe the morning one is combined, but then you see a split in the regular and NPH. Why would you do that? Because maybe you're waking up in the morning, over here, you're waking up in the morning and maybe you're not getting enough and the blood glucose levels are too high, and so you have to shift that because throughout the night, because maybe that patient eats big meals at night and it's fattier, so it's delayed. I don't know. You know, you have to, again, tailor it to your patient's lifestyle and their needs. These are intensive therapies that are 4-shot regimens, again, assuming no pump. So all of these are feasible options. They just require more work, right? And so again, the bolus to basal ratios typically are one of those two at the beginning, right? And then you have to adjust. So I just hope that you can appreciate the point of what I'm trying to show you here is the variety of options when you have a variety of dosage forms in a patient with unique situations. So you can see that I might add on a long-acting or an intermediate-acting like NPH at night, and that's it. I could consider it twice-a-day NPH because they're failing metformin or something else, and there are other non-insulin-based regimens. Nothing wrong with that. Is it going to be the best? Between these two, which ones would I prefer? Hands down, I would prefer a basal insulin because there's no peak. It mimics the more likely physiologic effect. So the patient's more likely to tolerate it. I'm probably going to get the more desired effect, but this is a more expensive option, may not be feasible. Or maybe I'm dealing with somebody who's done this regimen the whole life and they just know it and they feel comfortable with it and they don't want to change it. Or I have a patient that says, look, doc, I'm only going to give myself 1 shot a day and that's it, period, end of discussion. Well, okay, fine, I respect that. But we're stuck with something like that. Or if we go this direction, we're going to get it, but we're going to have problems potentially. It's not going to be as effective. So you see, I hope that you understand why all of this stuff matters. Now, let's kind of move into a couple other dosage form issues that I think are important for you to also know as you wrap your mind around some of these things. Insulin should largely be clear. If it's not, something could be wrong with it. Now, the exception to that is NPH, which is known to be cloudy. Now, historically, we teach we don't mix cloudy with clears, and there are some limitations on insulins that you can mix together. In general, you shouldn't largely do it except between regular and NPH, okay? And the order that you do that is also important, okay? So that you don't cross-contaminate, i.e. you don't want to put NPH cloudy into the regular insulin vial. So, but in general, you need to know that NPH is the one that has more of a suspension and you have to kind of roll it to distribute the medication in your hand. You don't shake it. It's a protein molecule, so you don't want to destroy the insulin itself, so you just roll it, okay? What about U500 formulations? You're going to see U100, U500, all this stuff. This is really designed for patients who are on high doses of insulin requirements. And that usually is a patient with type 2 diabetes. And so the volume that you are having to inject to overcome the insulin resistance to achieve the desired therapeutic effect on their glucose is just getting burdensome with the volume of insulin they're injecting. And so the U500 is a concentrated version of insulin in a vial that can create high risk for error. So you should always teach your patient and also yourself read the vial and of any medicine that you're drawing up. Do I have the right drug? Do I have the right concentration? Do I understand the dose that I'm administering so that I don't overdose the patient? And so there's even that for the Humalog quick pen for patients that need to smaller increments for their injections, right? But all of these run the risk of significant weight gain at this level. Now, the inhalation version, remember that's that ultra rapid, short-acting option. Dosage formulation, the biggest thing that you need to remember is obviously if you're inhaling something into your lungs, patients with known chronic lung disease like COPD or hyperreactive airway disease like asthma, your risk of causing bronchoirritation or spasm is clearly there, so we typically avoid them. We usually have to get baseline spirometry. That helps us to understand their pulmonary function before and afterwards, and especially in patients with underlying disease, because this will obviously affect their compliance and adherence. The pumps, they come with cartridges. They are formulated and have excipients in there that help them to infuse, again, create more of that physiologic response. And this is just one of many. I'm not going to cover all of them and every little nuance with every pump, cartridge, and thing like that. But just recognize that the type of insulin used, the excipients, which are the things mixed in it, some of them containing like vitamins in there and other things, and to help facilitate the kinetics to allow its absorption and stability in that environment in the way it's being administered. I do want to take a moment to talk about DKA dosing. This is on the acute side. These patients have abnormal lipolysis. They are usually patients with type 1s, and their blood sugars are, moderate to high. That's maybe not as high as HHS, but these patients require usually IV insulin therapies. We heard earlier when I was talking about giving insulin IV in hyperkalemia. We're doing that because insulin will drive the potassium inside the cell. Well, that may be appropriate for hyperkalemia. It's not going to be helpful in DKA, where the acidotic environment and acidosis that's going on causes a shift in the potassium from being normally inside the cell to come out of the cell. And then when you have high glucose levels like in DKA, you can then cause a lot of loss of that glucose in the urine, and then the potassium is following it. And so patients can become severely depleted in their potassium and their total body potassium stores. Remember, potassium is a major intracellular cation. And so you have to be very careful early on when you're treating DKA to check that potassium level before you start bolusing and starting infusions and all this other stuff. Okay, so that's a take-home point. Make sure you look at that potassium before. So we'll always start IV fluids, order labs, then get the potassium, and then decide how much insulin am I going to give the patient. Or do I have to give that patient potassium first before I give them any insulin? I have to do that all the time. This last little bullet down here at the bottom is talking about flushing the IV tubing. Unfortunately, insulin is known to bind to plastics and tubes and things like that, and that can change the overall concentration that you're administering to the patient. As you're starting them on DKA dosing, just realize that the most common drug that is used is regular insulin. That is typically the standard of care. We're infusing it so we can control it. We don't have to worry about subcutaneous administrations and their pharmacokinetic curves. It's just going straight into the body. So there's strategies of infusions that are based on bolus or no bolus. We generally don't like to do boluses. We're not trying to treat just the glucose number. We are trying to change the biochemistry and the metabolic derangement that's going on, and that doesn't happen like that. So boluses are typically not always needed. We want to treat the numbers and we bring them down by about 50 to 70 milligrams per deciliter per hour until they get around that 200 to 250 window milligrams per deciliter bubble. And then we need to convert them and start adding on glucose, but continue the insulin pump or insulin infusion. Because again, we're trying to transition their body into a state of forming keto acids to going back to utilizing glucose appropriately to form and make ATP. But you got to watch that potassium. This is not meant to be a whole discussion on how to treat DKA, but in the context of using insulin in these scenarios, that's why it matters. Now, most of the time we are administering these by subcutaneous injection, and typically we do that in the back of the arm, the thigh, the buttocks, or the abdomen. Abdomen is fairly common, so is the back of the arm. Why? We don't want, those are typically muscles that people are not using as much. Bigger muscle groups can absorb more. That changes the absorption kinetics. And so you just need to make sure that you not only clean the site, but you also rotate the sites of injection. You want to clean it, like I said, you don't want to necessarily pinch it super tight, or especially in thin patients, but you inject at a 90 degree, or if they're really thin, you would do it at a 45 degree angle, okay? Avoid the cold injections that can cause a little bit more pain and discomfort, and again, that's more relevant for patients who are kind of just don't like the shots to begin with. If you use pens, do not draw the insulin out of them. You keep the insulin in the device, okay? And so that becomes very important. But make sure they can read it, they can see it, they can use it. So if you have a patient with arthritis, rheumatoid, degenerative joint disease, they may not be able to do the clicks and turn it, read it. What if their vision is off? They don't wear their glasses, or they have cataracts or poor vision, macular degeneration, and diabetic retinopathy, and all these problems. Then you may not be able to utilize that dosage formulation appropriately in that patient scenario. Now, hypoglycemia. One of the areas of hypoglycemia that I wanted to make sure that you were aware of is what happens at night. There is a condition called the Somogyi effect, and that's listed here on this table in the top rows there. Getting too much intermediate or basal insulin at bedtime. So why does that happen? The only way you're going to know that is to have patients wake up at 2 or 3 o'clock in the morning and see if their blood sugars are plummeting in the middle of the night. Remember, if we have a longer acting insulin that peaks in the middle of the night while we're sleeping, patients can have these severe hypoglycemic episodes, and then what ends up happening is they wake up, if they don't have seizures or somebody else doesn't see that something's wrong, they wake up in the morning and they'll have these stress-induced elevations in their blood sugars. And you don't want to check the blood sugar over here in the morning and go, wait a minute, your blood sugar is high. Oh, you're not getting enough bedtime dose of your insulin, so we're going to crank it up. Well, that would just make this worse if that's happening. Versus the dawn phenomenon, which is mainly related to no hypoglycemia in the middle of the night, but is due to the normal diurnal variations of the growth hormone and cortisol release that occurs. So when they wake up at 2 or 3 o'clock in the morning and they check their sugars, it's normal, okay? So dawn phenomenon, Somogyi, is very important to differentiate before you start manipulating, especially increasing that nighttime NPH or intermediate dose so you don't cause it to get worse. Side effects, we talked about weight gain. That's huge. Don't forget about bariatric surgery. Patients, they start losing weight, their insulin requirements are going to come down. We have edema, fluid retention issues, TZD combinations, which would also cause that. Again, these are probably related more to the progression of the disease and the weight gain. Hypokalemia risk, especially because it drives it into the cell. Monitoring, we get that A1C, and again, you're going to be doing it very repetitively until they get to control. Once you get to control, you can consider, especially in a type 2, not type 1 though, a type 2 patient, you can consider going over to a non-insulin, non-secretagogue option where it can work when blood sugars are actually better controlled. You're monitoring CMPs or BMPs, mainly looking at serum creatinine because that will affect the kinetics of the insulin. Insulin is partially going to be removed in the kidneys, and so when your kidneys are having impairment, they're not going to be cleared. The drug's not going to be cleared. That could cause more hypoglycemia in those situations. Patients with acute care scenarios, don't forget, if they have hyperkalemia, you administer insulin, you need to give them glucose. You're not giving glucose to treat the potassium, you're giving the glucose because the insulin you gave to drive the potassium in the cell is going to drop the glucose, whoever the patient is, all right? If you're treating DKA, if you start out at a low potassium, remember, you've probably got total body potassium stores that are depleted. And so you want to be very, very careful before you do that. As far as storage of insulin, it's important. It's a protein, so you can denature it in heats, extremes, and being outside in room temperatures can cause them to break down, which loses its potency, efficacy. And so that varies for different products over time, but generally you got about 28 days at room temperature. Insulin Degludec, insulin Glargine, U300 expire after approximately 56 days. Those can sometimes be nuances for board exam questions and things like that for some patients. I did want to talk about drug interaction potential issues. Patients on beta blockers are going to potentially have blunted adrenergic response to a hypoglycemic episode, but they will still have the ability to sweat. Okay? Sweating is not regulated by the adrenergic system. So you're not going to block that part. So remember, when patients develop hypoglycemia, they have tremors, shakes, they just don't feel right. Well, that's not going to happen. If you won't have palpitations, you're not going to have tremors, you're not going to have shakes as easily with beta blockers on board, but you will still have sweating. Pramlintide, drug interaction, that's a huge one. Remember, pramlintide is one of our amylin analogs used for patients predominantly for type 1, although type 2s can use it too. But it works on that postprandial glucose level for people that really want tight control. Well, if you start somebody on pramlintide and they've already on insulin-based treatment, you want to make darn sure that you reduce that insulin requirement by 50% the day you start pramlintide, because you will affect the timing of glucose delivery to that area, the time when the insulin is supposed to be present and will be present, but that glucose won't be there. So whatever glucose is in the blood is going to drop. So if it already starts out low, you're going to make it lower, and that's not good, okay? So pramlintide insulin regimen, if you're not sure about that, you don't understand what I'm talking about, I discussed that in the amylin analog lecture that's available also at thisiswhy.health. So make sure you understand why that can happen, because that is dangerous and can be a life-threatening situation. Special populations, pregnancy, insulin typically goes up and the requirements go up. The problem with that is that women, unfortunately, develop more weight, and so does the actual baby, so that can make actually the delivery process complicated, but it is what it is. You've got to make sure that you get it in there and you adequately keep their blood sugar under good control, and that's where insulin pumps may be preferred over multiple injections, just because it's going to be hard for these patients to manage all this. All right, guys. Woo! It's a lot. Insulins, I mean, we got a lot of options, and that's great, right? So when we're treating type 1 versus type 2, we need some variety of treatment options and approaches because they're not the same, right? So those short-acting, rapid-acting, and long-acting and options give us some flexibility on how to manage those patients. But remember, type 1 and type 2 are not the same in their insulin sensitivity. But we're replacing insulin that is needed, or the insulin that is present is not enough to bring it down in type 2. And we want to get that metabolic control under better regulation. But there is a risk of side effects. Hypoglycemia, edema, weight gain in particular is a big one. Injection site reactions, okay? So insulin works, it's very effective, but you've got to use it correctly. And I hope you found this to be helpful in the context of understanding the other drugs. And I do a whole series on anti-diabetic drugs. So if this is the first one you happen to watch, it's good to understand it in the context of the other ones. And so I'd encourage you to watch those. Those are available at YouTube, also on our podcast channels. Over at thisiswhy.health, we offer free membership so you can download these images and download tables. But there's also playlists and collections that you don't find in other areas like on YouTube and things that we put there for you. So I'm Dr. Busti. Thank you so much for being here. Thank you for investing in your knowledge. I respect you for doing that. Thank you for what you do for patients and your service and as you help people. Because when you understand why you do what you do, it makes it easier and it actually makes it fun to take care of patients because you see the outcomes improve for these patients. So take care. We'll see you next time.